Okay, two types of stroke again, between ischemic and hemorrhagic stroke. According to statistics quoted by this textbook, it says 87% are ischemic and about 13% is hemorrhagic stroke. So I gave you a description, brief description already during lab. So there are different terms here. We used to call this cerebrovascular accident or brain attack. Now we just simply call them stroke. So same concept as the MI. So you remember ACS, right? So same risk factors as in acute coronary syndrome because this is just a different artery. So this one just involves the cerebral and the carotid arteries, but it's the same risk factor. So smoking, obesity, diabetes, uncontrolled diabetes, hypertension, etc. Okay, so same because it's all caused by atherosclerosis. Okay, and I already described the three risk factors for hemorrhagic stroke, namely severe hypertension, AVMs, and aneurysms. Okay. So for treatment here, therefore, since it's similar to risk factors for acute coronary syndrome, treatment will be the same. So patients after a stroke, will they still also be on aspirin and Plavix? Yeah. Yes, because remember, the patients after a stroke has the risk factor, so therefore they could have another stroke in the future. So we treat them the same way as, maintenance, okay? So preventing another heart attack, preventing another stroke entails the same treatment, okay? The same preventive measures. Let's go now to the manifestations. So you're familiar with BFAST. That's the common notices we stamp on posters in doctor's offices, public places like libraries, for instance, or the post office, right? We place them everywhere where people congregate, but obviously this is not enough. We need to share this information as much as possible in your own communities, let's say in your apartment building, for instance. Maybe expand the posters, okay, to include the manifestations we have listed here. So numbness of the face, arm, legs, so that's included in BFAST. Now, this one though, confusion and change in mental status. Okay, so if the confusion is acute, meaning a patient is usually fine or this is not their baseline, let's say the patient has dementia, but they're not behaving their usual self. Okay, so dementia patients have a certain baseline behavior, but then if their behavior changes, it could be anything, could be an infection, case UTI, for instance, or pneumonia, or it could be a stroke, right? Then trouble speaking or understanding speech. Okay, so this is what was happening to our faculty member that had a stroke about 6 years ago. So she was just unable to respond. Okay, so she was alert, but she cannot verbalize. She cannot speak. Okay. Visual disturbances, of course, this is very subjective. So the patient will have either partial or complete blindness in one or both eyes. By partial blindness, it sometimes is weird because, let's say, for instance, I had severe migraine headaches before wherein my right eye would go blind. I can only see through my left eye. And I was checked out, of course, because they thought it was a stroke. For these patients, we'll look at the eye changes later. It's on a table. There's something we call hemianopsia. Now, hemianopsia means you're blind in one half of your visual field, meaning you're only half blind in each eye.
Oh, okay.
Right? So that's a weird visual vision loss because unlike my symptoms wherein I was totally blind in one eye, at least I can see with this eye. Now, if you're half blind in each half of one eye, so it could be the right half of each eye or the left half of each eye, or sometimes it's weird, like you only have the tunnel vision or peripheral vision. Okay, so it varies, but any visual disturbances are suspicious for stroke. Okay. So emphasize the visual disturbances. Okay, so not just the blurred vision, but especially partial blindness. Okay, difficulty walking, dizziness, or loss of balance or coordination. And then finally, sudden severe headache. Sudden severe headache is more characteristic of hemorrhagic stroke, but we include them here anyway. So as already emphasized this morning, so our brain controls most of our sensory motor functions, our cognitive function, depending again which artery is involved, because each artery uh, in the brain supplies a specific lobe or hemisphere in your brain. So it's just a matter of luck, okay? Which artery was involved. They will spell what kind of doom you will experience. Okay. Some people will have a combination of sensory and motor loss. Again, depends on the region of the brain involved, which hemisphere, which lobe. Common problems, motor problems we have ranges from either paresis, which is weakness, or plegia, which is paralysis. Communication loss, there are two types here. We have in both cases, we call them aphasia. Now, do not confuse aphasia with dysarthria. There are two different problems. When we say aphasia, this is a cognitive issue, okay? Meaning this is a speech issue. Speech meaning, can you formulate language or can you understand language? Dysarthria is more of a motor paralysis. Okay, it's a muscle paralysis. It may not involve aphasia. Okay, so let's say you only have dysarthria, meaning your bulbar muscles are involved. You have no aphasia, meaning you're capable of understanding and right. You just cannot make speech. All right, but you can write down what you mean, or you can make gestures. Okay, so you understand the difference? Yeah. Okay, dysarthria, I'll take dysarthria anytime because I can still communicate through writing. Okay, or I can make gestures or I can mouth my words, but I cannot make a clear speech. Okay, that's dysarthria. I wouldn't want to have aphasia. Aphasia can be either receptive or expressive. Most stroke patients though have global aphasia, which is mixed. They have both receptive and expressive aphasia. Expressive is they cannot articulate, they cannot formulate what they want to convey, meaning they're unable to communicate. Okay, and that frustrates the patient. The patient will, because their cognition is intact. Okay, they know what's going on, but they just cannot express what they want. So when these people have expressive aphasia, can they work? Impossible. How do you work? You cannot communicate. Okay, there's no job that doesn't entail communication. What about receptive aphasia? Even worse, they cannot understand what you are talking about. So you speak to them, they have no idea of what you're talking about. They cannot comprehend what you're telling them. Okay, so again, most patients have mixed. Okay, they have both expressive and receptive aphasia. Apraxia is different. Now, apraxia is a motor problem. Motor as in command. Okay, so when we say apraxia, inability to perform a previously learned action. Now, does everybody know how to wipe their butt? Mm-hmm. These patients can't do that anymore. Do you know how to take a spoonful of mashed potato and put it in your mouth? Yes, everybody knows how to do that. These patients, if they have apraxia, they cannot do that anymore. You clear? Okay, so you ask them to do something. So apraxia therefore is a command. Okay, you ask them to do something, right? And they can't do it. Then there's perceptual disturbances, like I already described hemianopsia. So homonymous hemianopsia, homonymous means the same side. So it's either the left half or the right half of each eye is blind. Sensory loss, this is now agnosia. There are different types of agnosia because there are 6 senses, correct? We have the smell, sight, taste, sound, so and tactile, okay, touch. If you have agnosia, depends what type of agnosia do you have. Agnosia is you cannot recognize the object. I give you the remote control, you see it, but you don't know what it is. You don't know that. If you don't know what it is, what are you going to do with it? You don't know what to do with it. So agnosia, however, is not exclusive in stroke. We see this a lot in severe dementia. So in advanced dementia patients, they have tactile and visual agnosia. So if you give them a tray of food, what will they do with it? Because they don't know what it is. You give them a tray, okay, food. They don't know what it is. So much less, they don't know what to do with it. So that's why people with stage 4 dementia, what will happen to them? They're given a feeding tube, okay, because they don't know how to eat anymore, okay, because they have agnosia, right? So we notice this around stage 3. So they start having agnosia, and you probably notice it in the nursing home. When you give them a tray of food, they'll repeatedly do this. Open the tray, right? Open the cover. What is this? And then a few seconds later, what is this? Repeatedly. Okay, so that's when these patients start deteriorating because they don't eat anymore. Okay, and then caregivers don't know, and staff, for instance, you don't educate your CNAs that these people have agnosia. You just leave it. I didn't want to eat. No appetite. All right, not knowing that this is agnosia. Okay. So again, it can be visual, auditory, or tactile. Can this be dangerous? Yes. Let's say imagine this patient's living at home and there's stove, okay? That they open the stove, things like that, right? Or let's say, yeah, or let's say the car horn. They don't know what that is. They hear it, but they don't know what is that car horn, right? So consider that, okay? So no matter how you honk at somebody and then you end up hitting them, you can't say, oh, they weren't listening. Okay? They ignored me. Well, they have agnosia. They have auditory agnosia. They hear you, but
They don't know what they hear.
the hell is that sound? Okay? And there's cognitive impairment. So this will be same as in dementia patients. And they'll also have, especially if it's frontal lobe stroke, they will have some cognitive and emotional changes. So they'll have emotional lability. So they can go from laughing to crying to getting angry all at the same moment, right? So they'll switch from one mood to another. So you'll see these patients with stroke that behave like this. So it's frustrating, right? So especially for the family. So they're out in public and the patient is behaving like this in a public setting. Say you take them to a daycare center and they have one of these moments, right? It can be dangerous. And then also look at how it is perceived by the other patients. Okay, so this can cause conflict. It upsets everybody. So it can also range from limited attention span, forgetfulness, or just lack of motivation, right? So no two stroke patients are alike. Did I get the message across? Okay, because it really depends what part of your brain suffered a stroke. So you can't say, oh, stroke patients, I know what a stroke patients look like. No, you don't. Okay, again, no two stroke patients are alike because you don't know which lobe got the stroke. So our table 62-2 gives you a summary of the deficits. So from visual to motor, motor ataxia is mentioned here. So this is the gait change. So puts them at risk for falling. And of course, this is the part. So your physical therapist will, of course, assess all the deficits. So they'll integrate everything from their visual. Do they have agnosia? Okay, and then the aphasia as well. and they'll make a plan for the rehab. Okay, what activities will benefit the patient best. Okay. So don't think that, oh, all the PTs do is just, exercises. No, they have to formulate a plan based on the patient's deficits. Okay. So different professionals are involved here. So not just the physical therapist, there's also occupational therapy, there's the speech therapist as well. In fact, every stroke patient, they are automatically NPO until a speech language pathologist sees the patient. Okay. Of course, in certain cases, we uh, do a test swallow at the bedside, meaning let's say it's the weekend, right? So weekend stroke patients, there's no speech therapist available. They don't work weekends. They come in Monday to Friday only. So if there's no speech pathologist, that means will the patient be NPO the entire weekend? That's possible, but you can take the initiative. We can do a test swallow. Okay, I mean, you're not stupid, you're nurses. So do a test swallow. Let's say put 5 ml of liquid into the patient. Can they swallow that? If they do, then you don't see any coughing, any sign of aspiration, you report that to the doctor, and the doctor will give you a diet order, right? Until the official speech evaluation comes first thing Monday, right? But until then, keep the patient NPO. So we don't want any pneumonia, aspiration pneumonia. I won't test 62-3. This is too specific. So you can, I mean, it's nice to know. Okay? If you really want to know, it's good. Get nice information. Okay, so let's go to diagnostic tests. So as I described earlier, when we suspect stroke, what's the first thing we do? Time, okay? Right. Look at the time. Yeah, so what I mean is you saw one or more of the signs and symptoms of stroke. So you suspect stroke. So what's the first thing you do? Look at the time and call 911. Okay, immediately call 911 or take the patient yourself to the emergency room right away. The benefit of 911 is, let's say you're in a heavily congested area. Okay, you live in the city, so you're better off with a ambulance. Okay, who knows? You may have the NYP ambulance that has a CAT scan on board. Okay, you see the benefit of that service. If there's a CAT scan in the ambulance, what will your patient's outcome be? Right, because we get the diagnosis right there in transit to the hospital. So instead of waiting 10, 15 minutes to get out of place, we're already getting the out of place in the ambulance. Does that make sense? Okay, so the sooner you get it, then the more tissue, the more brain tissue you save. All right, let's talk about TIA. Again, TIA stroke patients, no difference in the manifestations, exactly the same. They look alike. Only difference is these manifestations resolve completely in 24 hours, most less than an hour. However, does that mean we'll send the patient home? No, because can they have another episode the next minute? Yes. So these patients will still be admitted. We'll still treat them with, of course, aspirin Plavix, because do they meet the TPA criteria? No, because it's not a stroke, right? It was only a TIA. So they will be inpatient, and then we will work up the patient. What caused the patient's TIA? Is it cardiac or is it vascular? You understand? Okay, so patient will go into a telemetry unit, a cardiac unit. We monitor their heart rhythm. Is it cardiac in nature? Was it caused by dysrhythmia, AFib or aflutter? Or was it caused by, let's say, the patient's lifestyle? Are they smokers? Is it diabetes? Okay, is it hypertension? So plus we also need an ultrasound or MRI of the neck as well. So we examine the neck, we do neck studies. What is the amount of most likely you and me have some level of obstruction in our carotids. It's just at this age, you guys are young, you probably have less than 10% obstruction. At my age, I'm already middle age, halfway through the grave. I've probably got around 20-30%, okay, blockage in mine. So that's not enough though to cause symptoms. Symptoms start showing up if you're at least more than 80% blockage, actually 70% blockage, then you'll have manifestations already. So if it is a TIA, we educate the patient, okay, no different from a stroke. We give them the same stroke education because can they have a stroke next time? Yes, because they already suffered the TIA, okay, just lucky that the clot was not big enough, okay, not big enough to cause an infarction. There was ischemia though, but temporary. So the gold standard is a CT. If the CT is not conclusive, then the patient will be sent for an MRI. So let's start with prevention. We already know the risk factors under the acute coronary syndrome chapter. So we manage the same. So hypertension, there's DASH diet here included for hypertension. Eating healthier. Stop smoking. Chart 62-1 summarizes your modifiable risk factors. What are non-modifiable risk factors? Age, ethnicity, okay, and genetics. Okay, so here are your risk factors. As I said, we will examine your neck. Okay, we'll check the both carotids to see if there are any stenosis and at what degree. We'll discuss carotid interventions later under management as well. So we'll see if you have AFib, diabetes, high cholesterol, heavy alcohol consumption, hypercoagulable states, hypertension, migraine, all the way to smoking. So if the patient does have AFib, make sure they have anticoagulation. Okay, I showed you the 8 core measures for stroke. If there's any anticoagulation contraindication, including peptic ulcer disease, for instance, or if the patient, let's look at the, let's go back to ACS that you're refreshed on the contraindications for TPA. So if the patient has any of these contraindications, table. Okay. So here's the contraindications again. Now there are relative contraindications, but since the doctors make the decision anyway, we don't need to know that. But we do need to know absolute contraindications. Active bleeding, except of course menstruation. Menstruation is not a contraindication for TPA. Bleeding disorder, definitely. Hemophilia. History of hemorrhagic stroke. If you have an AVM, you had recent, when we say recent, in the last 3 months, uncontrolled hypertension and pregnancy. Okay, these are absolute contraindications. If the patient has any of these, can they receive TPA? We'll have to do the vascular interventions. Okay, that's the only option for those people. For antithrombics, when do we give again? If the patient received TPA,
24
when is
hours
the first dose of the antithrombic?
24 hours
24 hours later. So that's aspirin and or Plavix. Most patients are on dual antiplatelet therapy or dual antithrombic therapy. So that's both aspirin, baby aspirin, and Plavix, which is clopidogrel. As far as how long they'll be on it, the doctor will decide. But it's usually for life. And the goal will be, of course, to decrease cholesterol. So we take control of the atherosclerosis. So the patient will be put on statin or any other non-statin option.
So, Professor, back to the contraindications, if the patient has uncontrolled hypertension, you wouldn't try to bring it down?
No,
Okay.
because that's short term.
Okay.
When the patient already has history of severe uncontrolled hypertension, so we assume there's already vessel malformations there. Meaning we already know there could be some or more aneurysms already. So we control blood pressure with various drugs. So we can use ACE inhibitors or calcium channel blockers. I won't repeat the thrombolytic therapy. We discussed that already today, including dosing and the window. What's the window again? 3 to 4.5 hours. All right. Now, if again the patient missed the 3 to 4.5 hour window, but they're still within 6 hours, the doctors may decide to take the patient to the cath lab and then administer the thrombolytic, the TPA, the alteplase, intraarterially, straight into the cerebral artery involved. Endovascular therapies, that's one option, okay, the intraarterial administration of TPA. This more likely refers to carotid interventions. Okay. We'll discuss that shortly. So here, if patients ineligible for TPA, then this is the only option, okay, endovascular treatments. Priority again upon arrival to the ER is what? Okay. Rapid diagnosis of stroke. Okay, is this ischemic or is this hemorrhagic? So CAT scan or MRI is crucial. And as soon as that is determined, then we proceed with thrombolytic therapy administration. If the patient is within the window. Here are your criteria for TPA. And dosing, we finished. What's the limit again for the blood pressure?
180 over
185.
over one. Okay.
180 was probably 3 years ago, so they changed it. Okay, they went to 185 over 110. Used to be 180 over 105. They changed it higher. Now, why does it raise the blood pressure? The stroke, I mean.
Because of the.
Okay, let me discuss or
Flight or fight
describe.
system too?
Not really. So this is due to cerebral perfusion pressure. What is cerebral perfusion pressure? This is the minimum pressure required to perfuse brain tissue. Normal is between 70 to 110 millimeters of mercury. Now, in order to calculate CPP, we need MAP minus ICP. Now, I won't complete the calculation yet because this will be more relevant under head injury. But let me just describe why does the blood pressure rise when the patient has a stroke? So think of it as a protective mechanism, part of the brain's auto-regulation. Now, unlike the rest of the body, which is protected by the sympathetic nervous system as well as the renin-angiotensin-aldosterone system, correct?
Mhm.
The brain has a unique protection. It knows that if blood flow decreases to it, caused by either ischemia or let's say a rupture of one or more blood vessels, which still leads to the same thing, right? So if this artery supplies this part of the brain and this artery ruptures, is there blood flow to that part of the brain? No, because now the blood is all over here, not going to that part of the brain. So the body's response is to raise the blood pressure. Here's why. MAP, what's the formula again?
2 times diastolic.
2 times diastolic.
Systolic.
Okay, so let's say if your blood pressure is normal, by normal we say, okay, let's say 119 over 69 or 79. Okay, 119 over 79. So what's the MAP there? 79 times 2 plus 119 divided by 3. So my MAP is 92, correct? All right. After a stroke, because this part of my brain, let's say, died, okay? It had suffered an infarction, stroke. It died. What will form around anything dead inside the body? Will there be swelling?
Yeah.
Will there be inflammation? Will there be any capillary leak? Yes, right? So there'll be increase in blood and fluid volume and brain tissue volume, brain swelling, right? So therefore, will it occupy space in the brain? Yes, because the brain only contains 3 things. There's brain tissue, there's CSF, and then there's blood. Only 3 things, and that's 100%. So if you suffer a stroke, what happens to brain tissue around the infarcted area? Swells, right? Swells. There's swell, inflammation. What happens to CSF? Increase, because now if you have any swelling, those ventricles, they usually have openings, right? Canals. So what happens to those ventricles? Obstructed. So CSF production is steady, but drainage is impaired. Blood. What happens to blood flow there? Or especially if there's hemorrhagic stroke? Increases. So all in all, what happens to volume inside the cranium? Increases. So let's say our ICP, normal ICP is 10 to 15. Some books say 0 to 15. Fact is, what's the highest number?
15.
The highest normal? 15 millimeters of mercury. So if my MAP is 92 and my ICP rises to 20, what's my CPP? 72. Although technically normal, I'm just assuming that my ICP only rose to 20. What if this is higher? What happens to my CPP? It will fall below 70. All right. So therefore, what will happen if my blood pressure is, let's say, 160 over 90? What happens to my MAP? It's higher. So no matter how high the ICP goes, what's my CPP? it's between 70 and 110. You see it?
Mhm.
So therefore, is it therefore a protective response, protective mechanism by the brain?
That's
Yes.
exactly.
For this reason, do not lower the patient's blood pressure less than 140/90. Do not lower the patient's blood pressure below 140/90. You understand why though? So most doctors, don't be surprised. When you work in a stroke unit, the neurologist will order permissive hypertension. So that's the term we use, permissive hypertension. So we want the patient's blood pressure to be 170, 100, 105, okay, diastolic. We want it high. You, of course, will be worried, right? Are you not worried? Yes, you'll be worried like, oh my God, what are you doing? Why are we letting this patient's blood pressure go high? But do you understand now? Yes, this is the reason why. So don't be scared, okay? Don't be worried for your patient. That is important. Now, how long do we allow this? 24 to 48 hours only. So after a stroke, 24 to 48 hours, sometimes doctor will only allow it until 36, but let's say 24 to 48 hours, there is permissive hypertension because of this reason. Are we in agreement?
Mhm.
Do we understand each other? Okay, so on a test question, let's say on the NCLEX, patient's blood pressure is 178/103. What do you do? What do I need the map for? I know it's high. I know the map is high. So this is a stroke patient. So what do I do? Leave him alone. What's our limit again? 185/110. I repeat, another scenario. The patient's blood pressure is 180/105. What do I do? Permissive hypertension. Are we clear? All right. You understand why though? Yes, it's important to maintain cerebral perfusion pressure, which much at all the time must be 70 to 110. Because what happens is 60, yes, technically brain tissue is receiving blood and oxygen at 60. But if it falls below 60, brain cells die. So do you want let's say this is your mom. Do you want your mom's CPP to be right at 60, 61?
No.
What do you want it to be? 70, at least 70 or better. You understand?
Yeah.
All right. So don't go, picking an answer wherein you lower the patient's blood pressure. Okay, we actually worry if that happens. The patient's blood pressure falls below 140/90. The doctors will order some drugs or fluids to raise it. We okay? All right. There are exceptions, before I forget, there are exceptions to the extension to 4.5 hours. There are three exceptions. If the patient is, and it's not written here, I don't know why.
For PPA, right?
Yes, for the extension. Maybe it is. So where's the four? Okay, there's the 4.5 hours here. Okay. Okay, here it is mentioned. Okay. So the exceptions to extending it to 4.5 hours are the following. The patient is on anticoagulation. INR is above 1.7. Patient has previous stroke, has trauma in the last 3 months. 3 hours only. Okay. And the last one would be the patient's over 80 years old. I mean, they're 80. right? So if you extend it to 4.5 hours, what's the side effect again of a thrombolytic? Bleeding. Okay, do you want to risk an 80-year-old bleeding? Yeah, it's not. So if a patient has, let's say, over 80 years old, or they're on anticoagulation, or they had a previous stroke, head injury, or trauma in the last 3 months, what's the limit?
3 hours.
3 hours only. Okay, no extension to 4.5. Are we clear? All right. So look at the NIH stroke scale. I know the number is up to 11, but it's actually 13 because there's 2A, no, there's 1B and 1C. So that's actually 13. But don't worry, on your on Epic, it's a drop-down box. So I know it's long, it's 13, but it's clicking. Okay. But the assessment will take a long time. Okay, so this section is the other interventions to lower increased ICP because the patient after a stroke, again, because dead tissue is present. So of course, we expect an increase in ICP. Okay, so whether it's ischemic or especially if it's hemorrhagic stroke, there will be increased ICP. So we take measures to decrease ICP using the following. If needed, the doctor will administer or order mannitol. Mannitol is an osmotic diuretic. When you draw this drug up from a vial, it also comes in a glass vial. When you draw it up, please use a filter needle because when this interacts with the atmosphere, which happens when you draw it up, right? So there's air displacement, right? Between your needle and your syringe. So when it's exposed to the atmosphere, it forms crystals, microscopic crystals like powder. Let's say I spill it on my fingers. So after a few minutes, it will form powder around my cuticles. Okay, so that's the crystals. Okay, so you don't want to inject that crystal intravenously, right? It's microscopic, but it's still embolus. Yeah, okay, they're still emboline. So always draw it up with a filter needle. Your other interventions to manage increased ICP, which is again expected after a stroke and head injury, give oxygen. Now, the reason for giving oxygen to maintain 95% or better saturation is when the patient's CO2 levels rise, which happens, right, when your oxygen levels are low, CO2 is a potent vasodilator. Now, if there is cerebral vasodilator, so if the blood vessels in your brain dilate because your oxygen levels drop and your CO2 levels are high, what happens to blood volume in the head? It increases. And what happens to ICP? Increases. Elevation of the head, no higher than 30 degrees. Now, I won't repeat this when we get to head injury, okay? Because these are only mentioned in this section, right? This will not be repeated under head injury. Why? Why can't we elevate the head of the bed? Isn't it always 45 or higher? Why 30 degrees here? Okay, so at this angle, so let's say this is, that's 45, yeah? Or more like 60. Okay. This is 45. Yeah, that's 45. Versus if this is 30, that's 30. Okay, so this is 45, this is 30, that's 60. What happens to intra-abdominal pressure?
It's increasing with that one. With the 60.
What happens to intra-abdominal pressure here?
More.
Because you have a sharp hip flexion, yeah? So here, do you have a sharp hip flexion? No, that's a large angle. This is a close angle. So the sharper your angle, the sharper the hip flexion. And what happens to pressure against the diaphragm? Okay, so the abdominal pressure will push up against the diaphragm. So what happens to venous return from the head back into the heart? It decreases because once you have increased abdominal pressure, that increases the intrathoracic pressure and therefore decreases venous return from the head. And what happens to ICP? Increases. You understand? Okay. So what's the head of the bed elevation? 30 degrees, no higher than 30 degrees. This is kind of extreme. So some patients, if we cannot control, I don't really see this in stroke, but we see this a lot in head injury. So Bellevue is New York City's leader in head injury management. Okay, so they have the best doctors there, the best facilities. It's Bellevue. So if you have a chance there to observe, who's in Bellevue right now?
Where?
All of you?
Yeah.
Okay. Go to 7th floor. They have a TBI unit there. It's a rehab unit though. So I'm sure they'll let you in there. Those are the lucky ones. Okay, so those people survived traumatic head injury and they're there for rehab. Okay, so those people are miracles. So some of them will have hemicraniectomy. What is this? So the surgeon will remove a section of a skull, close the scalp back, put that skull somewhere in their abdominal wall. So a section of their head will be flat. Okay, so it'll be soft because there's no skull there. Okay, so whenever those patients are on your floor, they have to wear a helmet when you take them out of bed. So when you put them on a chair or anytime they're out of bed, you must put a helmet because what will happen if they fall? There's no protection. Okay? There's no skull, right? So it will appear flat. We intubate and put them on a mechanical ventilator if necessary to maintain oxygenation. Meaning, if these people's ICP is really high, think of it this way. So we know what are the 3 things inside the skull?
Tissue.
Brain, CSF, and blood, right? Okay, so it's already 100%. You agree? So it's 80% brain tissue, 10% blood, 10% CSF. Who has can you have that bottle, please, with the big mouth? Yeah, thank you.
Oh, sorry.
All right, if I fill this bottle up to the brim, can you add any more?
No.
If I add 1 drop, what will happen? What overflowed? The drop that I added?
Whatever was in there.
Or whatever was at the corner, right?
Yeah.
Okay, so if I do that, it will overflow. So it will just follow the path of least resistance, correct? You agree? Okay. So imagine this is the brain. I'll turn it over because there's only 1 opening in the adult skull. Where is that?
The base.
Right here?
No, like in the.
Okay, right here, where your spinal cord exits. Okay, we call that hole the foramen magnum. Right? So this is now my skull. This is the base of my skull. This is right here. So this is the only opening. You agree? All right. So just like a bottle, so if it's already full, filled to the brim 100%, I add 1 drop. What overflowed? The drop that I added?
Whatever was.
Something that was around the exit, right? Around the opening. So here, if this is the base of my skull, what's located at the base of my skull? What part of my brain is that? It's actually the brainstem, correct? Yeah, the brainstem because that's attached straight to the spinal cord, yeah? Okay. So which part of the brain will spill out? If I add volume, because remember, we increase the volume, correct? We added more brain tissue because it swelled. We added more CSF volume because it couldn't drain. And then there's also vasodilation because of the injury, right? Okay, so what will happen if all that increase? You said that if this was the bottle of water, it will spill. Is it a different story here? If I increase the volume here, I increase the volume of the brain tissue to 90%, blood to 15%, and then CSF 15% as well. So I have to account for a 15% increase. So I have to displace 15% worth. So if I displace 15% of the brainstem is larger than this opening. So if you if you push something soft into a smaller opening, what will happen to that tissue? Meaning it herniates. So what will happen to that herniated part? It's gonna be strangulated, right? So what happens to blood flow to the brainstem?
It decreases.
What are the functions of the brainstem? Not much. It's a primitive part of your brain. They only control breathing, only blood pressure, only heart rate. Okay? Nothing, only consciousness. That's all they do. Okay, because they're primitive. Nothing about knowledge. What do they control again? Just breathing, just heart rate, just blood pressure. Okay, just consciousness. So what will happen to the patient? All right. Okay, so what happens to the respiratory rate?
Decreases.
So is it sometimes necessary, therefore, to intubate?
Yes.
Yes, to maintain oxygen, you have to intubate. What did we say last week when we did GCS? What score needs to be intubated? 8 or less. Okay, so you can relate it now. Okay, so these patients, because what happens to the level of consciousness here? If you're herniating that brainstem, okay, the patient's level of consciousness will drop. Okay, so now you understand why the LOC drops and then why we need to intubate sometimes. Yeah, because they cannot protect their airway. Okay, the consciousness is so decreased, level of consciousness is also so decreased, they cannot protect their airway. Hemodynamic monitoring, of course, we need to maintain blood pressure again. Remember, permissive hypertension. Okay, we don't want that blood pressure to be too low. We need it moderately elevated. Okay, 140/90 or higher, as long as it's below 185/110. Here, of course, we don't want to allow the blood pressure, of course, to reach 220/120. That's too high, right? Frequent neurologic assessments and any deterioration, by the way. So deterioration, okay, improvement is always a welcome change. But any deterioration, let's say your your GCS score was 10, now it's 8, is that reportable? Yes, even if it was 15 and now it's 13, is that reportable? Okay, any 2-point or more deterioration. Why do we not want them to have a fever? Because will there be fever here whenever there's dead tissue anywhere? Yes, it will increase body temperature. So what is the effect of fever on ICP? Why? How? Vasodilation. So if you have high body temperature, it dilates all blood vessels, including cerebral blood vessels. And what happens to blood volume as a result? What happens to ICP? Okay. All right. And then with anything else, and I think Stephanie asked this today, right? About blood sugar. Okay. So blood sugar should be less than 180. Now this is a standard. You remember this in ACS, yeah? ACS and in shock also, yeah? So any patients with shock, ACS, stroke, any sepsis, okay? Any patient in critical condition, why do their sugar levels rise? Whether or not they're diabetic?
Loss of tissue.
Stress hormone. Okay, so stress hormones are high, blood sugar rises. And what is our target? Below 180. So you give insulin if needed. That's our target. It doesn't have to be normal because it's impossible most of the time. Plus, these patients are NPO, yeah? So they're once they're intubated, now they have a feeding tube. Yeah. So now we need to control the blood sugar below 180. Any questions so far? Okay, so we're still in the acute period. So we're still within 24 to 48 hours. Now, there are consequences here. So until the patient was brought to the hospital, there may have been some aspiration. Okay. And then there will also be more aspiration once we intubate the patient. We'll discuss airway management and mechanical ventilation week 11 or 12. So we have to deal with aspiration pneumonia for these patients. Plus, what's the head of the bed elevation again?
30.
Only 30. Okay, so we can't really raise it. So that is high risk for aspiration. And the rest are, of course, complications of immobility. Okay, so pressure ulcers, DVTs, constipation, nausea, vomiting.
Foley as well, right?
Not really necessary unless the patient goes into shock.
So when you put them on the bed,
No need really, because the mannitol here is a diuretic, but it's not like this patient had a cardiac problem. Does that make sense? If it's a cardiac, if it's a perfusion problem, yes, there's a cerebral perfusion, but it's not cardiac perfusion. Okay. Meaning we can assess tissue perfusion in the cerebral by neurologic assessment. So your Glasgow Coma Scale, right? So those are your evidence.
so like for our
And your
patient,
CPP.
So for our patient, how is it relevant? Because
What do you
they're
mean?
on, for our patient, for the
Oh, he's a stroke patient.
So the Foley,
No Foley. There's no need for Foleys in stroke patients. Okay, if there's a Foley order, then give it. But really, is it necessary here? Not really.
so where
Okay?
does the fluid from the ICU, like when you give them mannitol?
Okay, understand, mannitol is an osmotic diuretic. So do we really want for the patient to lose fluid? No, what's the good question though? So what's the purpose of giving mannitol? Which section did it all under? Right here, mannitol is mentioned here. What is the goal of mannitol here as a diuretic?
To decrease the.
This is all under what? All these interventions we're talking about, what are these? To lower ICP. So the mannitol was given to lower ICP. How? To decrease cerebral edema. Okay, so this will pull water from the
brain.
from the brain cells and also the interstitial space. It will pull it, take it out to the urine. So therefore, our evaluation is the ICP, not the kidney function. Does that make sense? Right. So it's not really it's not necessary to put a Foley in. All right, because our goal again is to decrease ICP. So this is the pharmacologic option to give mannitol to increase ICP patient. And these are the rest of the interventions. So let's finish stroke. For surgical options, we have CEA. So this is a violent cleaning of the carotid arteries. We'll have a picture here. Okay, this is CEA. So the patient will undergo cleaning of one or both carotids. There are complications related to this also, including a stroke. They could have a stroke during this procedure. So they'll clean it out. So they take out the plaque from the artery, opening it. Sometimes if it's not bad, they'll just put a stent in there. But if it's CEA, usually it's removal of the atherosclerotic plaque or clot.
This is for people with thrombotic stroke?
Yes, thrombotic. Now, these patients, the purpose of this procedure is not only to prevent stroke, but remember earlier, if the patient doesn't qualify for alteplase, what are their choices? Endovascular, right? Because so this is also therefore used to treat acute stroke. Okay, so but more of these procedures are to prevent another stroke. Okay, well, let's say they had a TIA, then yeah, so here TIA or mild stroke, this is an option. Okay, so for acute stroke, but more for prevention. So here, look, if you read the first statement, this is for patients with TIA, mild stroke, and CA is the removal of plaque to prevent a stroke. Okay, so for both acute management of stroke, endovascular management of stroke, and also for stroke prevention.
We do that.
It's the same thing. CEA, yeah, they're referring to the same. So as already mentioned, stenting is a option. Okay, if the carotids aren't that bad, so they can put a stent to keep it open. And here are your complications. So under management after CEA, okay, there's no table, so you'll have to read the entire paragraph. It's not that long. So one of the complications mentioned here is stroke. Um, Cranial nerve damage is also possible because you're manipulating the neck. You don't have to go into table 62-5. This is too long. This is the complete complications of CEA though, but you can stay with the what's written on the paragraphs. Okay. So I grabbed the questions from here. I didn't go to the table. You go back. And during the acute phase, these are the whether or not the patient received alteplase, these are your reportable findings. So decrease or change in the LOC, change in vital signs, especially if the blood pressure is too low or too high. All right. By the way, what were the causes listed under diabetes insipidus and SIADH?
Brain injury.
And stroke. Okay, so can these patients develop DI or SIADH? Yes, so monitor them for those. That's mentioned here under right here. Volume of fluids ingested or given, then volume of urine excreted for every 24 hours. Okay, because it could be increase, which is diabetes insipidus, or decrease, which is SIADH. Okay, that's it for stroke. The rest of these are rehab, which we won't test. But what did we say about diet?
Oh, then NP over until assessed by the stage leverage factors. Or you could try the 5 and